Our final speaker of the day requires no introduction, but I will introduce him nonetheless. 2018 was a very exciting year in Los Angeles. The Lakers got LeBron James, and UCLA got Dr. Van Arsdell. That has worked out for one of us, and it wasn't the Lakers. And since Dr. Van Arsdell started with us in October 2018, he's really brought a new dynamic, a new energy, a new focus, and really is uniting us behind this common goal of trying to provide the best possible patient care for all of our congenital heart disease patients. And he's really brought our congenital transplant game and adult congenital heart disease care really to a whole new level, and also, of course, pediatric cardiology surgery to a whole new level. So we're thrilled that he's chosen to return to the Los Angeles area. Dr. Van Arsdell did medical school, his surgery residency, and his CT surgery fellowship at Loma Linda under Dr. Leonard Bailey, who passed away recently. But Dr. Bailey inspired Dr. Van Arsdell to seek training in congenital heart disease surgery at Toronto Sick Kids, where they recognized his talent, obviously kept him on after fellowship, and he ascended to become chair of their division there. We were lucky enough to recruit him back to the LA area. And so without further ado, I'm going to introduce Dr. Van Arsdell here to talk to us about the Fontan operation, what have we learned, and where are we going next?
Well, it's good to be back in the LA area, I can tell you that. Mr. Townsend, you would have been one of the early Fontans in the world. And I say that because it's true that it was published in 1971 and the first operation was done in 1969, but it was not an easy path getting to where we are today. And not very many programs did it on a regular basis. And certainly Dr. Lax was very instrumental in the LA area, completely changing how congenital care was delivered and the operations that were done. And it's a storied program because of that history that Dr. Lax drove, and certainly it's one of the big reasons that I chose to come back to LA and to UCLA. I'll try to, I tell this story about surgeons. Surgeons, if you ask the surgeons who are the greatest surgeons in the world, they say, well, there are two of them. Some of you have heard me tell this before. Well, who are they? I can't remember the other one. So I'll try to not take that in mind when it comes to today's talk, because everybody has something important to say, and most certainly mine is not the most important thing to say, and I'll try not to keep you too long. But that said, I think that it's worthwhile taking some perspective on what we've been talking about today. Everybody thinks about Fontan, and you've heard about Kreutzer. Kreutzer independently did the same thing in Argentina that Fontan did in France without knowing about it. And this is kind of the natural evolution of things. More than one person thinks of a solution to a problem. And here's Billy Kreutzer. I had lunch with him 2 or 3 years ago. This is with one of his early Fontan patients that he reconverted to a more modern Fontan. And interestingly enough, in that first article, he talked about leaving a fenestration. These are all kinds of Fontans that have occurred. The classic one on the left, the Fontan Kreutzer. You heard about the Bjork modification. That may make a comeback. Mark de Laval in the 1980s, late 1980s, did the total cable pulmonary connection, which was very important in terms of changing the efficiency of the Fontan and impacting longer-term outcomes, as we'll see later. And then Puga of Mayo Clinic, working around with crazy hearts, came up with this idea, well, what about putting a tube in? And Marcelletti, who was Puga's fellow, thought, well, we can just put in a homograft routinely. And then they learned the homograph's stenosed, and you need to do it with Cortex. And then today, the most modern Fontan is the Y-graft, which is used very specifically using computational fluid dynamics to figure out how to distribute hepatic blood flow to both lungs so that you don't get pulmonary AVMs. Interestingly enough, every one of those surgeons I personally have spent time with. with the exception of Fontan, who, what an idiot I was for not taking the opportunity to meet him when he was still alive. But each of those, through kind of the course of my career, naturally, I ran into them and spent some time with them. Len Bailey, my mentor, made an all-natural Fontan, taking a pericardial roll. And then, of course, we know about the attempts at doing full interventional Fontans, setting them up at stage 2. And our own Dr. Lax made a very important contribution when, on a regular basis, he brought the concept of not only a fenestration, but an adjustable fenestration. So Fontan surgery's gone from, can you survive a Fontan? And I mean, that was a real question. 15 to 25% mortality in the early days. Aldo Castaneda wrote about, in the early 1991, we've gone from 20% mortality down to 4% mortality. I'm old enough to remember these patients coming in, and it was hard to get some of them through. Shock trousers, abdominal ventilators. You were pouring volume into them. We didn't know how to set up the Fontan. Incredible fluid shifts. That's where we were. And so people ask the question, well, can you avoid a Fontan? And that was a pretty fair question. Maybe you can just stop at a stage 2, do a cable pulmonary connection, and add an extra source of pulmonary blood flow. And that experiment actually did not work. And on the right-hand panel there, you can see the long-term patients that had to go on and be converted to either a Fontan or a transplant. Very few actually could live with that original arrangement because of exercise intolerance or too much cyanosis. Bill Norwood didn't just make the contribution of the Norwood, he made the contribution of saying, let's split the Fontan into 2 operations. And he designed this hemi-Fontan operation to make the lateral tunnel simple. Hemi-Fontan is a crazy operation, but a couple institutions did it well. I learned how to do it. I never liked it. It just seems so much simpler to do a cable pulmonary connection bidirectional shunt. But in his program, they dropped the Fontan mortality by 50%. And all of a sudden, you went from these big numbers down to today, what is Fontan mortality in the operating room? 1%. And you shift all the risks to stage 2 where you don't have so much of a problem with loading conditions. You do the pulmonary artery work and make them perfect at stage 2. Work on the atrioventricular valves, make them as good as you can at stage 2. And then the next thing that was really big was saying, let's extubate them in the operating room. Turns out, Texas wasn't the first to do it, but they codified it, and it turns out that you need less inotropes, you need less ICU time, you need less chest tubes. You need less hospital stay, and all the measured hemodynamics are better if you simply let the respirations help the pump work better using spontaneous respiration. So we've gone from, do you have to do a Fontan and can you survive it, to here's my buddy Yves Dudicum, who I can tell some stories about, put together this Fontan registry in New Zealand and Australia. And his comment is, it's not so bad. We had a feeling they were going to fall off a cliff, and we haven't seen them fall off a cliff yet. Although I think you're right, it's a leftward shift of the curve, Dr. Clift. And you can see the difference there between a modern Fontan and the old atrial pulmonary connection. But here's the problem with that, and this is my mentor, Bill Williams, who hired me, a big data guy. He didn't like just looking at what happened after an operation. He wanted to know that what happened from day 1. And I defy any of you in the audience here today to show me a different slope of the curve in the first 1 to 2 years of any congenital heart disease that's going down a single ventricle path. So it's true if you look at conditional survival, 1% mortality to do a Fontan, well, we've selected out a bunch of patients, and a bunch haven't made there. So we've got something to do as a society. And if you correct for that conditional mortality, you're looking at a 30-year survival probably in the range of 50% instead of 60 to 70%. It's true there are superior Fontans. Eve's group looked at a number of patients who had greater than 80% predicted exercise capacity. Most of them were left hearts. But they're not all there. So I'm going to suggest to you, if we're going to make progress, it's going to be in pre-Fontan mortality, avoiding Fontans when we can by capitalizing on modern tools of imaging and precision medicine, and then changing how we treat heart failure. And I want to spend a little time touching on each of those, not in the most detailed ways, but in some of the high-level ways. A few years ago, we held this internal conference at Sick Kids called 20 Years of Successful Failure. We'd been doing Norwoods for 20 years. And you think, well, you're doing a good job. When you look at the big data, it's really tough. So 10 years of utilization, 85,000 patient days for our program. The prevalence of hypoplastic left heart syndrome, or the Norwoods, was 3%. They utilized 10% of the days and accounted for 17% of the mortality. When you look at it in a big picture, it's not quite so good. And when you go through the history, you say, well, Bill Norwood designed a brilliant operation that gave us a solution. We had to learn something about the physiology, but then we got a better solution, we thought, with the RV to PA conduit. And then we got an even better one where we thought, well, let's don't do a big operation up front. Let's push it till later with the hybrid circulation. And what it turns out is each of those is in parallel circulation. And we had to work our way through to find out that every one of them has a curve that looks like this. And I won't show you the data, but we've got good data from Sick Kids looking at Norwoods versus hybrids. It's shaped just like this, and the outcomes are identical, and you're just choosing a different set of complications. So we've got this fundamental problem of, what is it? It's heart failure. Here's a weight growth curve of those babies. Put them all together, plot them on a z-axis, on a z-score, and they decline from almost being normal to being small, almost a z-value -2, until when? Until you create an in-series circulation, take away the heart failure, and they start growing. And here's real data showing that. This is measured VO2 data on hypoplast that we did 15 years ago. There's a couple things that are really important. So top panel, unstable, look at those curves on each individual patient going all over the place. If you average them out, their combined cardiac index is 4 to 5. That's running like crazy. On the bottom curves, you can see the pulmonary vascular resistance, which was variable, but not to the same extent of the systemic vascular resistance on the right curve. Now compare that to post-stage 2. In series, you now have a cardiac index at 2.7. No wonder they start growing. And of course, there's no new idea under the sun, but is it the in-parallel circulation that is a cause of mortality? And can we, on a hypothesis basis, create an in-series circulation as a newborn instead of in parallel? Well, Bill Norwood did that. And here's a case report of a patient who had 5 weeks of age, had arch reconstruction, and instead of a shunt, had a BCPS. And the comments are telling. The patient was stable, except passed away from hypoxia. So the question is, really, can we overcome this issue of hypoxia either through biologic assist or mechanical assist? And indeed, it turns out in animal models, and this is one of our nurse practitioners who went and got a PhD in lung biology, working on accelerating lung maturation in rats, and it turns out you can with the treatment of heparin. Well, we treated a bunch of our patients with heparin, and it made no difference. So it didn't translate from rats to humans. But it tells you the principle is there. And I can tell you today, on lambs, we've got a mechanism that we're doing mechanical, promoting through mechanical obstruction development of lungs. And you can see a change in PVRI, and we're trying to figure out whether or not you can change the actual alveolar capillary ratio. And it's conceivable that you could fetal accelerate, so biologic assist, fetal accelerate the maturation of the lungs so that you can skip this in series, in parallel circulation and go straight to in series. Well, Mark Rodefeld was the first to really think about, can we just do a Fontan as a neonate? And this was an acute experimental design that he did in pigs. Turns out you can do it experimentally. And I sat in the audience and I thought, well, that's a tough model because you're going to have to do it for 2 or 3 years. How about doing it for a month or 2 or 3 in a newborn? And here's the model that we worked on in pigs. In series, primary in series circulation with a primary cable pulmonary connection. And it shows that with mechanical assist, you can get some survival out of those pigs and that you protect cerebral blood flow. And without it, you can't. So in principle, it can be worked. So we took it to the operating room. Post-operatively, we ultrafiltrate patients. And you can you ultrafiltrate them to help the systolic and diastolic function and get rid of fluid. So it's something we needed to do anyway. And through the ethics board, they said, okay, you can change the rate you do it, and you can change it where you put the cannulas. And during the ultrafiltration time, you can study whether or not you can actually do this in humans. And it turns out this is what the model looks like. I won't go through in detail, and I'm not going to go through this in detail either, other than to tell you this. It worked. So the brain was protected, the blood pressure was okay, you could get adequate oxygenation, and where expected, the hemodynamics were better. And this I will focus on. This was a hard number to get, and we only got it on 2 patients. But if you look at a mechanical assisted cable pulmonary connection cardiac index versus the Norwood cardiac index in the same patient, you can see the protection that you might get from heart failure. Well, this was the team that helped us do all this. On the top right, you're going to hear more about Osami Hanjo, who came to my lab and could hardly speak English, and now is one of the backbone surgeons at Sick Kids. And he's got some other interesting work that he's taken to the next level. So these are some potential scenarios where this might work. Here's a cable pulmonary shunt where you could just offload the SVC and run it through an oxygenator, do partial lung oxygenation in a newborn in a scenario where maybe we could make a difference. And then in the cath lab, you could pull out that catheter, plug it with a nitinol plug, and have a stage 2 completion without actually operating. Or you could do right heart assist alone. This is creeping into the literature, not as a primary therapy, but as a rescue therapy. And as we worked our way through the ethics of this, it's difficult ethically because you know there are going to be problems with it, and you know you're going to create a new set of problems. But this was what our team was coming to at the time, was if we can find the right situation ethically to do it, this is the one that we'll test. Well, there are problems, neonates, inflammation, emboli, all kinds of things. And as an old teacher of mine said, you don't cure it, you just create a new problem, which is true. The question is, are we going to create better problems? Another area where we can make progress is in these marginal zone patients. Is it a 1 ventricle repair or is it a 2 ventricle repair? So there is no question that some patients, the only option is 1 ventricle. There's also no question that there are obvious 2 ventricles. But there is this zone in the middle where the decision is not entirely clear. And it is a zone of temptation. And the reason it's a zone of temptation is if you get it wrong in history, you can see a mortality as high as 50%. And so we're very cautious about that, rightly so. But this was an important paper that came out of Montreal in the late 1980s with this idea of there are patients who have small left sides that actually can be used. And Christo Chervenkov calls this a hypoplastic left heart complex. They were duct dependent, but the idea was that if you loaded them in time, that ventricle would grow, and if the structures were normal enough, you would then have a ventricle that actually worked. And so it was an intriguing concept. The flip side of it is if you're looking only at anatomy, and this is from the Congenital Heart Surgeon Society, anatomy says that some of these structures, if they reach a certain size of smallness, So your outflow being in the 4 millimeter range, look at your survival, only 60% survival. Some of these binary things that you look at in various locations are incompatible with two ventricle repairs. So the question then becomes, how do you change these borderline hearts, or can they be changed? And I want to talk to you a little bit about what we've learned about that through a combination of imaging and through a combination of inducing growth. So for functional adequacy, it's not just anatomic. Anatomy and function are highly correlated, but not 100% correlated. So to have an adequate systemic ventricle, you need good contractility, you need good diastolic function, you need an adequate inlet, you need an adequate outlet, you need valvular competence, you need adequate minimum size. Those are kind of variables that all come together and they become function. They're not binary, they're correlated. You can't put them out separately. So here's how we started looking at this. So let's take the days before MRI. Borderline left heart patient, I used to ask them, well, take them to the cath lab, plug the duct, plug the ASD, let's see what happens. And then we realized, well, let's just do it in the operating room. So here's a case, small left side, 6 days, coarctation, ASD. And here are the loading conditions. Left atrial pressure is 12 millimeters. You've got a good systemic blood pressure. Plug the ASD, left atrial pressure goes up to 35. Is this patient going to tolerate a two ventricle repair? Well, we haven't finished the study yet. What's the next thing you do? Plug the ductus. All of a sudden, left atrial pressure is 10, unrepaired. Blood pressure 70. Pretty good idea. If you fix the coarc, patch the arch, maybe leave an adjustable ASD, this kid's going to do okay with a two ventricle repair if you don't ask it to have too high a cardiac output. Well, these guys came along, Shijun Yu, some of you have met, who made two really important contributions to us at Sick Kids. One was, I can do neonatal MRIs, and I can do them for you without intubating them. We figured that out as part of the process. And I can give you flow, which was the first time we had real functional measurements, real time. And then he went on and got into printing 3D models, which I'll touch on in a little bit as well. But here's a look at some of those same patients. Here's echo, various kids, 3.5 kilos, mitral valve Z sizes with Z values that are quite small, and left ventricular end diastolic volume index calculated by our team at the time by echo. Here's the early MRI data. Look at the difference in the left ventricular end diastolic volume index, much bigger, routinely bigger, although not 100% correlated. And you could go through, and this was before the flow data, we could calculate, beat by beat, if you had a 75% ejection fraction, what your cardiac index was going to be. So if you had this volume of 22 and your heart rate varied between 115 and 165, assuming a 70-ish% ejection fraction, there you've got a cardiac index that's survivable. And so it raised our game, and it turns out that there are a number of patients this was useful for. And with the MRI, you could calculate theoretic sizes of enlargement once you change the loading conditions. And here you can see ABSDs didn't enlarge too much, AS did, but each of them had true versus potentials that were a bit different. And the flow data that became available, can't remember if it was the same time or not, but was really interesting because we were interested in what's the cardiac output in the ascending aorta in the unrepaired state. And all these patients underwent two ventricle repairs, and you can see in the unrepaired state, ascending aortic flow was an index of 1.5, way different than what we think about in adults. And as low as a bit over 1, and sometimes a bit over 2. So you show me today an MRI with an index of 1.75 and a borderline ventricle, there's a functional measurement that's telling you that kid's going to do okay. So we took to leaving adjustable ASDs, repairing the arch, doing an intracardiac repair if we needed to based on that data, and you would see this accelerated aortic growth, but not so convincing for the mitral valve, and the mitral valve becomes more and more important in terms of a limitation for these patients. It wasn't perfect, though. Sometimes some of these kids would come back with pulmonary hypertension, and you may have actually sent them down a transplant tract if you didn't convert them back to a single ventricle early enough. But here's a look at what MRIs can do for you. Here's a 2-month-old 4.4 kilo transitional AVSD, falls way over on the left-hand side of the AVVI index. The kid had a parachute mitral valve and moderate regurgitation. No mural leaflet. Are you going to do a single ventricle repair or a 2 ventricle repair? Here's what it looks like. That is a small valve. MRI shows a big enough ventricle, 42 index volume. That's pretty good. But what do I want to know? This is what I want to know. And when you see that cardiac index of 2 in the ascending aorta, you know, even though that left AV valve is really small, if it's a transitional defect, it's taking a cardiac index at 2, and it's going to be okay. And sure enough, it's not a perfect repair. You've got a small mean gradient. You've got some regurgitation still. You can't close the cleft as much as you want to. We measured the index postoperatively in the OR, and it was 1.25, but the kid did great. These are completely different numbers than the adult side, and over time, they'll be okay. So then we learned also that some of these patients that we did hybrids on, you could actually delay your decision making on whether you're going to take them down a 1 ventricle or 2 ventricle repair pathway. And I would say this is the most important thing we learned from the hybrid experience. So I call it a temporary left-sided 1.5 ventricle repair. So the right heart's still doing a lot of work for you. Here's a very small left ventricle, indexed at 24. Originally, I would have repaired this straight up. Today, I would do a hybrid on them. Mitral valve's 5 with a Z of -5. Do a hybrid on this kind of heart, they're home fast. How about 7 months later? Weight's gone from 3.5 to 7 kilos. The LV index has gone from 24 to 41, and the Z value of the mitral valve's gone from -5 to -3. Simple operation, adjustable ASD in case you need a pop-off, home in a few days. You can grow some ventricles. And here's a look at a series of patients. You can see a fair bit of growth from down in the 20 to 30 range up into the kind of 50 plus or minus range for most of them. You can see one there that didn't grow. So here's something that we also kind of stumbled on. If you get in the operating room and the valve is better, the mitral valve is better than you expect, maybe it shouldn't be a 1 ventricle repair. So you can sew in an artificial duct and do an arch reconstruction. So here's a Gore-Tex duct. You can resect EFE, some of the EFE at the time, and set this patient up for some growth. We haven't published this data yet, and it's not perfect, but it is another way of saying, oh, if you need to do a Roscono and you need to do some mitral work and you need to do some further EFE resection, you don't also have to do an arch reconstruction at the same time, and you may be able to split these big operations into 2 so you get a better outcome. I would say this. Here's a situation where we got it wrong. LV volume is 37, should be big enough. Ascending aortic flow on MRI was 0.15. We pushed, did multiple operations, Roscono. Here you can see there's clearly no LV outlet obstruction. The LV volume at 32 mils should be good enough. And even after doing all that, the ascending aortic flow is only 0.7. We listed the child for transplantation, unfortunately. Not soon enough. Believe the functional data. It's more important than the anatomy, both ways. Here's an example from here that's not Fontan related, but I want to show you the power of functional data in MRI. So this is an interrupted aortic arch complex patient who had a Yasui repair. So for those of you who don't think about this all the time, a Yasui means you make both the pulmonary artery and the aorta as your outlet, tunneling blood through the VSD and do your arch reconstruction. Then you have to add a conduit in. The problem with the conduit is it sits right behind the sternum and gets compressed. So this child wasn't doing so well. let's do an evaluation. And I looked at the echo, and I know there are multiple ways of treating these. You can do a Roscono up front. You can say, I'm going to make that aortic valve work, or you can do a Yasui. Let's get an MRI. So we did an MRI. Guess how much blood flow is going through that native aortic valve now? 3 liters with a peak of 6. If you go above the DKS, the total output's 3.6, which means only 0.6 is going through your pop-off side. When this child needs a conduit change, the child doesn't need a conduit change. We can change over to being a standard in-series biventricular repair and get rid of conduits for this kid for the rest of their life. The power of functional imaging, that wasn't necessarily a bad decision up front. It was a safe decision. And now you have a chance to make a change. So functional imaging is real. We got to believe it. You can do it in a way in babies that you don't have to put them to sleep to do it. The volumes are always greater than what we see on echo, although not a linear correlation. And then, of course, the potential left ventricular and diastolic dimension is bigger than what you see initially, and we have been able to see some growth. So I want to go a step further into precision medicine and precision imaging. Imaging is everything. It's what I've seen. I've seen progress in this field in my career in 2 areas that have been profound. One is the understanding of physiology and how much better Norwoods had made us at taking care of patients. The second is incredible advances in imaging. So what is this? Anybody want to take a guess? This is a CT scan of something. You know what it is. I guarantee you know what it is. What is it? That's the power of 3D imaging. So here's a situation, 200% double outlet right ventricle, one of the most complex things congenital heart surgeons see. It is the last operation I teach because it's so many variations and so much complexity. I looked at this data and I said, I don't know, it might be a single ventricle in my mind. Well, let's get more advanced imaging. So let's get axial imaging. So out comes the axial imaging. This is what it looks like. You can see a big anterior aorta, a generous sized VSD right there. This would be where the tricuspid inlet is. So you can't do a Rastelli from here to here. It'll block your tricuspid inlet. So it's a single ventricle, right? Here's the subvalve region. Is that going to... In another view, you'll see there's dramatic subvalve stenosis. Well, you spend a little time with it, and you print a 3D model, and you dice it, and you slice it, and you plan your operation before you go into the operating room. And what we came up with was if we can get rid of that subvalve stenosis safely without destroying the tricuspid valve, we can probably enlarge the VSD, and we may be able to do an arterial switch. If not, we may be able to do an aortic root translocation, and only if we can't do one of those 2 things will we move over to the single ventricle pathway. But very clearly, the model showed we could not do a Rastelli. And here's a child postoperatively. You can't really tell what was done because the tunnel was so complex, but there's no outflow obstruction. We've done an arterial switch. We've enlarged the VSD. We've cut apart part of the tricuspid valve and put it together again, getting rid of that subpulmonary stenosis, and the child has a nice biventricular repair. The power of precision medicine and imaging that has advanced dramatically. This may not make the difference in surgeons' hands who are used to doing it, but if you want to flatten the world, this is how you flatten the world and say, some patients that didn't need a Fontan actually don't have to have a Fontan because you've got the imaging and the ability to plan beforehand. Here's a case that Shijun Yu likes to tell about. He was irritated at me because everybody in conference said it needs to be a single ventricle or something like that. I don't remember the exact details. And he took the time and printed the model for me, and I didn't pay any attention to it. And then I can't remember if he paged me or it was the morning of surgery, and I go looking for him. Where's the model? I pick it up, I look at it, about that long, set it down, walk out, say it's a 2-ventricle repair. And he loves to tell it because he realized it helps him understand the power of the imaging. And this is the model. And this is holding it in your hands, and you can look at it and figure out, see, I could see from there that I could tunnel it. And whatever the obstruction was, you could cut out and you could deal with. And here is the actual identical patient, comparing the model, labeled identically. It's a very clear representation of what you need to do in these most complex cases. Now, I can tell you an experienced surgeon would figure that out in the operating room, but it's far better to be able to figure out beforehand. So fortunately, Greg and Ashley and some of the team, when I arrived, hopped onto it. Those models used to cost us $400 or $500 a piece to print, but Greg went and found all this freeware, bought a $1,500 printer, got some cheap stuff, and he prints these models for me now for $2 a piece. It's not, now his time's a lot more valuable than that, obviously. They're good enough. And we'll update our printers and we'll get there with time. But I think one of the other things that's really clear out there is there are patients out there that have Fontans that may not need Fontans. Or if they have Fontans, you may be able to actually take them down to a systemic right ventricle. And this is a buddy of mine who's now at Cleveland Clinic who just presented 5 cases, unbalanced ventricular septal defects, corrected transposition, straddling issues. He took them to the operating room and took their Fontans down, converted them to systemic RVs because that's how he could turn them into 2 ventricles, and took them from unpalatable Fontan situations to something much more tolerable, either a 1.5 ventricle repair or something with better saturations. Big operations, and you have to choose the patients very carefully, just like you have to choose your Fontan liver transplants. I'll show you one more of these just to give you the power. So this is a terrible Fontan situation. Trisomy 21, unbalanced AVSD, who's had fortunately has done okay with palliation so far. But when you look at it, you have to ask the question, can you do a 2 ventricle repair? And so you get an MRI, and it turns out the volume's 21 cc's in a 2 or 3-year-old. That's not big enough. But you have to ask the question, what about doing an arterial switch and a hemi-atrial switch so that you have a systemic RV? We know trisomy 21 Fontans don't make it very far. So these are the kinds of things that advanced imaging allows you to do. We probably will rewrite the book over time on borderline size AVSDs, complex tunnels, straddling. There are many patients out there who would now be adults who have straddling as their reason for a Fontan, and you can replace that valve as an adult and turn them into a 2 ventricle repair. So what about the failing Fontan? Mark Rodefeld, I'll come back to this. You saw this slide earlier. He has really dedicated his life to saying, can we create some kind of low-powered system that's implantable? And this is this viscous impeller that shows a dramatic improvement in left-sided loading conditions just with barely ramping up power on the right side. And this is just the data. You have other people chasing after dual pumps from top to bottom, and you can see you get a better support on the top line from dual pumps than you do with single pumps versus no pumps. Here's an ingenious one that is conceptually out there, which is to use the power of the systemic side. So you load a BT shunt effectively in to drive this pump and add energy. And you can see each of these strategies potentially improves the power on the right side so that you get better throughput. This is my partner Osami Hanjo again, who took it to the next level and said, well, what about can we support the Fontan? And this is in press right now, and it's a concept of cannulas where you use an inflow port and an outflow port. So the inflow port is this portion, suction lumen, and these are your 2 ejection lumens that can be fashioned to drop into each limb of the Fontan, and you can see all the favorable hemodynamics. This is a partnership between engineering and surgeons saying, we've got to find some solutions. This won't be a long-term solution, but it might be a rescue strategy for helping the kidneys, getting the child ready for or the adult ready for a transplant, where you can drop their CVP and get them. It'll be like having a right-sided inotrope, effectively. So this is something that I hope you hear more from us about in the near future, and that's what I call big questions. We had a team called the Labatt Family Heart Center. It came from an endowment from the Labatt Beer family, although the money was actually real estate money, not Labatt beer money. And they had a passion for helping medical advances. So the endowment helps drive research. There was some capital spend that we said, well, can we spend it any way we want? And they said, well, yes, you can. So we had $1 million. We sat down as a team. We said, we want to make a difference. Let's treat something that can be treated like a venture capital business and try to make a difference to patients. So, you have an option. You can start a business by saying, I'm going to start from scratch. Or you can start a business that says, there's somebody who's an expert out there, and let's partner with them. So these two guys on the left, this guy, I didn't have a job for, but I hired him because he's going to be a superstar, and you're going to hear about him. This guy's a resident in the University of Toronto system, and he's getting a PhD. And I had 2 messages for him. When I hired him, I said, would you be willing to do a PhD? Yeah, I'd love to. This guy, I said, look, if you're going to do it, we have to get you to partner with somebody. If you want to be a neonatal surgeon, come to me, come to Sick Kids. We got a machine. We'll produce you into being a neonatal surgeon. If you want to be a good researcher, don't come to me. Go to the machine that makes great researchers. Let me tell you about the machine we got them linked up with. Once we put $1 million on the table, people wanted to talk to us. Before we put $1 million on the table, good idea, not so interested. Gordon Keller, Michael LaFlamme started Blue Rock Therapeutics, backed by Bayer and a venture capital firm. $225 million. The whole purpose? Cell therapy to make a difference in patients. A neurologic arm, a cardiac arm, and when they started hearing about hypoplasts and these guys, pretty soon they're on the team, both now in the throes of their research getting PhDs. And it's exciting because there's this preliminary work out there independent of this and different strategies, but patient tests. You're all familiar with the Shunji Sano data out of Okayama where cardiac progenitor cells are injected into the coronaries and we see better ventricular function. I actually think we've got a chance at this. In kids, it seems to be different than in adults. And it may be that you can change the adults so that they're more like the kids, or the treatments so that they're as effective as they are in the kids, with some of this high-powered money that's beginning to come into this. We need to be part of that conversation, and those guys, 2 guys, are helping us be part of it as a community. Some of you have heard this story, and I'm going to tell it for those of you who haven't. But Jamil, can you stand up for me, please? Jamil, how tall are you? Okay, Jamil's 5'7". Imagine that he's a little bit bigger, 240 pounds. He's got a kind of a colored past, so it's okay if I tell this. Walks into a bank, looks at the camera, walks up to the teller, points a gun and says, "Give me the money." Have you ever done that? The teller hands over the money. Wheeler is this guy's name. Goes back out into the community and is shocked when he's arrested 2 hours later. And the cops he says, "How did you know it was me?" And they said, "What do you mean, how do you know it was me?" He said, "Well, you looked right in the camera." "Yeah," he said, "I looked in the camera, but I wore the juice." Now the cops are totally confused and say, "What do you mean you wore the juice?" "Well, I put lemon juice in my eyes." "What are you talking about?" Well, somebody told me if you put lemon juice in your eyes, the cameras can't see you." Read about it. Errol Morris, a brilliant storyteller in the New York Times. There it is, 2010. Psychological anosognosia. Wheeler didn't have enough insight to know that he didn't have enough insight. Or you could use different words. Why do I tell that story? Well, there's two reasons. One is if you shed light on it, it turns out the academic studies show you start getting better insight. So today we've been shedding light on a big, big deal. The second reason is because I'm going to submit to you that we have anosognosia about Fontans. And not too far in the distant future, I hold more hope than what we have today. Thank you.